diarrhea, and constipation. Welcome to this presentation on two of the most common gastrointestinal complaints, diarrhea and constipation. These conditions may seem minor, but they can significantly impact daily life and even signal underlying health concerns. Today, we will explore their causes, symptoms, and management strategies to help improve digestive health and overall well-being. Epidemiology of diarrhea. Diarrhea affects people worldwide, impacting millions every year. Over 1 billion cases of acute diarrhea occur annually, making it a leading global health issue. It's not just an inconvenience. It can lead to dehydration, hospitalization, and even fatalities in severe cases. In the United States alone, 100 million people experience diarrhea annually, with 3.4 million requiring medical attention and 130,000 needing hospitalization. Economic burden of diarrhea. Beyond the physical toll, diarrhea imposes a heavy financial burden. In the U.S., the annual healthcare costs linked to diarrhea reach a staggering $8 billion. This excludes cases caused by chronic inflammatory conditions like IBD, inflammatory bowel disease. Additionally, it leads to 3.4 million emergency and clinic visits per year, with 130,000 hospitalizations, straining both individuals and healthcare systems. Epidemiology of constipation. On the other end of the spectrum, constipation is another widespread digestive concern. It affects between 12 to 19% of the population, with women being twice as likely to experience it as men. In the U.S., constipation and related conditions contribute to 5 million clinic and emergency room visits each year. The average cost per patient? A hefty $3,500, almost double that of individuals without constipation. Normal gastrointestinal physiology. To understand diarrhea and constipation, we first need to look at how the gastrointestinal GI system functions. The small intestine is responsible for digesting and absorbing nutrients from food, while the colon plays a key role in regulating water and electrolyte balance. Meanwhile, bacteria in our gut help salvage nutrients by breaking down undigested carbohydrates, influencing digestion and stool formation. Neural control of the GI function. Digestion is more than just the movement of food through the gut. The nervous system plays a crucial role in regulating gastrointestinal function. The enteric nervous system, often called the second brain, consists of specialized nerve networks controlling digestion. Additionally, the autonomic nervous system modulates gut movements and secretions using neurotransmitters like acetylcholine, serotonin, and norepinephrine to keep everything running smoothly. Intestinal fluid absorption and secretion. Every day, our digestive system processes approximately 9 liters of fluid. Of this, only 1 liter reaches the colon, and a mere 0.2 liters is excreted as stool. This delicate balance of absorption and secretion is crucial. Any disruption, whether too much fluid absorption, leading to constipation, or excessive secretion, causing diarrhea, can create significant digestive distress. Colonic motility. The colon isn't just a passive storage organ. It actively moves contents through specialized contractions. Mixing contractions blend contents without propelling them forward, while high-amplitude propagated contractions push stool along the colon, occurring about 5 times daily. After meals, the colon undergoes a postprandial response, increasing contractility for up to 2 hours to aid digestion and bowel movements. Defecation process. Having a bowel movement is a complex process involving multiple physiological steps. It begins with rectal distension, triggering relaxation of the internal anal sphincter. Then the puborectalis muscle relaxes, straightening the rectal angle to facilitate passage. As intra-abdominal pressure increases, the external sphincter voluntarily relaxes, allowing stool to exit. Any dysfunction in these steps can result in constipation or incontinence. Definition of diarrhea. But what exactly is diarrhea? Clinically, it is defined as the passage of abnormally liquid or unformed stools with increased frequency. Quantitatively, a stool weight greater than 200 grams per day in adults on a Western diet qualifies as diarrhea. It is further classified by duration. Acute lasts less than 2 weeks, persistent spans 2 to 4 weeks, and chronic extends beyond 4 weeks. Conditions to distinguish from diarrhea. Not all loose stools are true diarrhea. Some conditions mimic it, but require different treatments. Pseudodiarrhea involves frequent, small-volume stools, often with rectal urgency. Fecal incontinence is an involuntary loss of stool due to neuromuscular dysfunction. Meanwhile, overflow diarrhea occurs in individuals with fecal impaction, commonly seen in elderly or bedridden patients. Causes of acute diarrhea. Acute diarrhea can have various causes, but in over 90% of cases, the culprit is an infectious agent. Bacterial, viral, and parasitic infections are common triggers. Other non-infectious causes include medications, toxic ingestions, ischemia, and even food intolerances. Identifying the root cause is essential for appropriate treatment and prevention of complications. High-risk groups for infectious diarrhea. Certain individuals are more vulnerable to infectious diarrhea. Travelers are at high risk, with up to 40% of tourists developing traveler's diarrhea. Food consumers at picnics, banquets, or street vendors face contamination risks. Immunocompromised individuals, daycare attendees, and institutionalized persons, such as those in hospitals or nursing homes, also have increased susceptibility to infections. Pathophysiology of infectious diarrhea. Different microbes cause diarrhea through various mechanisms. Toxin producers like Vibrio cholerae and E. coli lead to profuse watery diarrhea. Enteroadherent organisms such as Giardia cause mushy stools. Cytotoxin producers like C. difficile can cause bloody diarrhea, while invasive organisms such as Shigella provoke inflammation and fever. Understanding these mechanisms helps guide targeted treatments. Non-infectious causes of acute diarrhea. Not all cases of diarrhea stem from infections. Medications, including antibiotics, cardiac drugs, and NSAIDs, can disrupt gut function. Ischemic colitis, commonly seen in older adults, presents with abdominal pain and bloody stools. Meanwhile, exposure to toxins such as arsenic or contaminated seafood and food allergies can trigger sudden, severe diarrhea. Identifying these causes is crucial for effective management. Approach to acute diarrhea. When faced with acute diarrhea, the first step is a thorough assessment of severity, duration, and patient history. Some cases resolve on their own, but others require medical attention. Warning signs include profuse diarrhea, dehydration, bloody stools, fever above 38.5 degrees Celsius, prolonged symptoms beyond 48 hours, or severe abdominal pain. Identifying these red flags helps determine whether further testing is necessary. Management of acute diarrhea. Managing diarrhea effectively depends on the cause and severity. Fluid replacement is the cornerstone of treatment. Mild cases can be managed with oral rehydration solutions, while severe dehydration may require IV fluids. Symptomatic relief with antimotility agents like loperamide can help, but these should be avoided if infection is suspected. In moderate to severe cases, especially those involving bloody stools or fever, targeted antibiotic therapy may be necessary. Chronic diarrhea. Overview. When diarrhea lasts more than 4 weeks, it's classified as chronic diarrhea. Unlike acute cases, most chronic diarrhea is non-infectious and requires deeper investigation. It is categorized by its underlying mechanism: secretory, osmotic, Steter-Hill, fat malabsorption, inflammatory, or motility-related. Proper diagnosis is crucial because chronic diarrhea may indicate a more serious underlying health condition. Secretory causes of chronic diarrhea. Secretory diarrhea occurs when there is a disruption in the fluid and electrolyte balance in the intestines. It leads to large volume watery stools that persist even during fasting, distinguishing it from osmotic diarrhea. Common causes include certain medications, chronic alcohol consumption, hormone-producing tumors, and even congenital disorders affecting ion transport in the gut. Osmotic causes of chronic diarrhea. Osmotic diarrhea results from poorly absorbed solutes drawing excess water into the intestine. A key characteristic is that it stops when fasting, meaning if the patient avoids food or the triggering substance, the diarrhea resolves. Common culprits include osmotic laxatives, lactose intolerance, and carbohydrate malabsorption, such as infructose or sorbitol sensitivity. Steatorrheal causes of chronic diarrhea. Steatorrhea refers to fat malabsorption, leading to greasy, foul-smelling stools that may float. This type of diarrhea occurs when the digestive system fails to properly break down or absorb fats. It can be caused by pancreatic insufficiency, celiac disease, or small intestinal bacterial overgrowth. A key diagnostic sign is stool fat content exceeding 7 grams per day. Inflammatory causes of chronic diarrhea. When diarrhea is accompanied by abdominal pain, fever, and blood or mucus in stools, inflammation is often to blame. This can result from chronic infections, inflammatory bowel diseases, or IBD, like Crohn's disease and ulcerative colitis, or microscopic colitis. Inflammatory diarrhea is typically diagnosed through stool tests, blood markers, and colonoscopy with biopsy. Notice here, dysmotility. Causes of chronic diarrhea. Sometimes chronic diarrhea stems from abnormal intestinal motility, where food moves too quickly through the digestive tract. This can mimic secretory diarrhea but often has an underlying neurological or metabolic cause. Common triggers include hyperthyroidism, diabetic neuropathy, and post-surgical changes. Treating the root cause is key to managing symptoms effectively. Approach to chronic diarrhea. A structured approach is necessary to diagnose chronic diarrhea effectively. This begins with a detailed medical history and physical exam, followed by basic lab tests. Stool analysis helps assess inflammation, fat content, and infectious agents. Endoscopy and imaging may be required if an underlying inflammatory or structural disorder is suspected. Identifying the right cause ensures appropriate treatment. Treatment of chronic diarrhea. Managing chronic diarrhea requires a cause-specific approach. If a particular trigger is identified, like a medication or food intolerance, removing it can bring relief. Antidiarrheal agents such as loperamide or bile acid sequestrants help control symptoms, while nutritional support ensures adequate hydration and nutrient intake. In some cases, newer therapies like secretagogues and microbiome modulation offer promising solutions. Definition of constipation. Constipation is more than just infrequent bowel movements. It involves persistent difficulty, straining, and a feeling of incomplete evacuation. While bowel movement frequency varies, most people pass stools at least 3 times per week. Symptoms like hard stools, bloating, and discomfort are key indicators that a person may be suffering from chronic constipation. Factors influencing perception of constipation. The way we perceive constipation is influenced by multiple factors. Stool form and consistency are linked to transit time. Hard, pellet-like stools suggest slow movement through the colon. Cultural and psychological factors, such as early toilet training experiences, can also shape one's expectations of normal bowel habits. Additionally, medical history, such as reliance on enemas, provides insight into the severity of the condition. Pathophysiology of constipation. Constipation can have several underlying causes. The most common is inadequate fiber and fluid intake, leading to dry, hard stools. Other causes include colonic transit disorders, where stool moves too slowly, and anorectal dysfunction, affecting the muscles used for defecation. Additionally, medications like opioids and systemic diseases such as diabetes or hypothyroidism can contribute to chronic constipation. Causes of recent onset constipation. When constipation develops suddenly, serious underlying causes must be considered. Colonic obstructions such as tumors or strictures can physically block stool passage. Anal sphincter spasm, due to conditions like hemorrhoids or anal fissures, may make defecation painful and difficult. New medications, particularly opioids and antidepressants, can also slow bowel movements, requiring careful evaluation and management. Causes of chronic constipation. Chronic constipation often stems from functional disorders, structural abnormalities, neurological conditions, or endocrine imbalances. Irritable bowel syndrome or IBS-C and slow transit constipation are common functional causes. Structural issues such as rectal prolapse or megacolon can obstruct stool movement. Neurological diseases like Parkinson's and multiple sclerosis may impair bowel motility, while metabolic disorders like hypothyroidism and diabetes also play a role. Approach to constipation. When evaluating constipation, a comprehensive approach is essential. This starts with a detailed history and physical exam, including a digital rectal examination. Basic tests like blood work, thyroid function tests, and serum calcium levels help identify metabolic causes. If symptoms persist or alarm features are present, such as weight loss or rectal bleeding. Colonoscopy or imaging studies may be needed to rule out serious conditions. Management of constipation. Treating constipation often begins with simple lifestyle changes. Increasing fiber intake, drinking more water, and regular physical activity can significantly improve bowel movements. Laxatives such as bulk forming, osmotic, or stimulant types may be used as needed. In cases of pelvic floor dysfunction, biofeedback therapy helps retrain the muscles involved in defecation. For severe cases, newer medications like prucalopride or linaclotide offer targeted relief. Severe constipation. Additional investigations. When constipation is chronic and unresponsive to treatment, further investigations are needed. Colonic transit studies using radiopaque markers or scintigraphy assess how quickly stool moves through the colon. Anorectal manometry measures sphincter pressure and rectal sensation, while defecography evaluates pelvic floor function. A balloon expulsion test is a simple bedside method to check for impaired defecation. Complications of chronic constipation. Left untreated, chronic constipation can lead to serious complications. Fecal impaction may result in bowel obstruction, requiring manual removal. Hemorrhoids and anal fissures develop from straining, causing pain and bleeding. In severe cases, rectal prolapse occurs where part of the rectum protrudes through the anus. Managing constipation early prevents these distressing outcomes. Special populations. Constipation in pregnancy. Constipation is a common complaint during pregnancy, affecting up to 40% of women. It occurs due to hormonal changes, the growing uterus compressing the intestines, and reduced physical activity. Management includes increasing fiber intake, staying hydrated, and using safe laxatives such as bulk forming or osmotic agents when needed. Addressing constipation in pregnancy is crucial for comfort and maternal health. Special populations, pediatric constipation. Constipation is one of the most common pediatric complaints, accounting for 3% of outpatient visits. Causes range from dietary factors and toilet training issues to psychological stress. Treatment focuses on education, dietary adjustments, and behavior modifications. In some cases, laxatives may be prescribed, but the goal is always to develop healthy bowel habits for long-term relief. Special populations, geriatric constipation. As we age, constipation becomes more prevalent due to reduced mobility, medication use, and age-related changes in gut function. The risk of complications such as fecal impaction and bowel obstruction is also higher in older adults. Management includes hydration, fiber intake, and gentle laxatives, while ensuring that underlying conditions, such as neurological or endocrine disorders, are properly addressed. Irritable bowel syndrome, or IBS. Irritable bowel syndrome, or IBS, is a functional gastrointestinal disorder that affects 10 to 15% of the population. It is characterized by abdominal pain and altered bowel habits, without structural abnormalities. There are 3 subtypes: IBS-D, diarrhea predominant; IBS-C, constipation predominant; and IBS-M, or mixed type. Understanding IBS is key to improving quality of life for millions of individuals worldwide. Diagnosis of IBS. The diagnosis of IBS is based on clinical criteria rather than laboratory tests. According to the Rome 4 criteria, IBS is defined by recurrent abdominal pain associated with defecation or changes in stool frequency or form at least 1 day per week for 3 months. However, it's crucial to rule out red flag symptoms like weight loss, nocturnal diarrhea, or blood in stools, which may indicate more serious conditions. Management of IBS. Managing IBS requires a personalized approach. Dietary modifications such as the low FODMAP diet can help identify and eliminate trigger foods. Medications, including antispasmodics, antidepressants, antidiarrheals, or laxatives, are used based on symptom type. Psychological therapies like cognitive behavioral therapy and hypnotherapy have also been shown to reduce symptoms. In some cases, probiotics may provide additional relief. Inflammatory bowel disease, or IBD. Inflammatory bowel disease, or IBD, includes 2 major conditions: Crohn's disease and ulcerative colitis. Both cause chronic diarrhea, abdominal pain, weight loss, and fatigue. However, Crohn's disease can affect any part of the GI tract with patchy inflammation, while ulcerative colitis is limited to the colon and rectum with continuous inflammation. IBD is a lifelong condition that requires careful management. Diagnosis and management of IBD. Diagnosing IBD involves a combination of endoscopy, imaging, blood, and stool tests. Treatment aims to control inflammation and prevent complications. Anti-inflammatory drugs, immunosuppressants, and biologics are used to manage symptoms, while surgery may be needed for severe cases. Regular monitoring and lifestyle modifications play a critical role in improving patient outcomes. Celiac disease. Celiac disease is an autoimmune disorder triggered by gluten ingestion, affecting about 1% of the population. When people with celiac disease consume gluten, it damages the small intestine, leading to diarrhea, malabsorption, and nutrient deficiencies. Beyond digestive issues, it can cause fatigue, joint pain, anemia, and even neurological symptoms. Diagnosis and lifelong management are essential to prevent complications. Management of celiac disease. The only effective treatment for celiac disease is strict lifelong adherence to a gluten-free diet. Even small amounts of gluten can trigger intestinal damage and systemic inflammation. Nutritional support is crucial to correct deficiencies in iron, calcium, and vitamins. Regular follow-ups help ensure dietary compliance and monitor for complications such as osteoporosis and increased risk of lymphoma. Microscopic colitis. Microscopic colitis is a chronic inflammatory disorder of the colon that often presents with chronic watery diarrhea, particularly in middle-aged women. Unlike other forms of colitis, it appears normal on colonoscopy but requires a biopsy for diagnosis. Treatment typically includes budesonide and other anti-inflammatory medications, along with symptom management strategies such as dietary modifications. Functional gastrointestinal disorders. Not all digestive issues stem from structural abnormalities. Functional gastrointestinal disorders, or FGIDs, are conditions where the gut-brain interaction is disrupted, leading to symptoms like pain, bloating, diarrhea, or constipation without visible disease. Common FGIDs include IBS, functional dyspepsia, functional constipation, and functional diarrhea. Diagnosis is based on symptoms and exclusion of other conditions. Anorectal disorders. The anorectal region plays a crucial role in defecation, but various disorders can affect its function. Hemorrhoids, swollen blood vessels in the anal area, can cause pain and bleeding. Anal fissures, small tears in the anal lining, lead to discomfort during bowel movements. Fistulas, abnormal connections between the anal canal and skin, often result from infections. Rectal prolapse, where rectal tissue protrudes through the anus, is more common in older adults and requires medical attention. Gastrointestinal infections. GI infections can be caused by bacteria, viruses, or parasites. Bacterial infections like Salmonella and Shigella often lead to fever and bloody diarrhea. Viral infections, such as Norovirus and Rotavirus, are major causes of acute gastroenteritis. Parasitic infections, like Giardia, may result in chronic diarrhea. Treatment depends on the cause. Some require antibiotics, while others resolve with hydration and supportive care. Clostridium difficile infection. Clostridium difficile is a bacterial infection often triggered by antibiotic use. It causes severe diarrhea, abdominal pain, and fever, and is common in hospitalized or immunocompromised patients. Diagnosis is confirmed by stool tests for C. diff toxins. Treatment includes specific antibiotics like vancomycin or fetixomycin, and in recurrent cases, a fecal microbiota transplant may be considered. Gastrointestinal motility disorders. Motility disorders occur when the normal movement of the digestive tract is disrupted. Gastroparesis results in delayed gastric emptying, causing nausea, bloating, and early satiety. Intestinal pseudoobstruction mimics a mechanical blockage, but occurs without an actual obstruction. Hirschsprung's disease, a congenital disorder, affects nerve cells in the colon, leading to chronic constipation. Diagnosis and treatment vary based on the specific disorder. Gastrointestinal bleeding. GI bleeding can occur in the upper or lower digestive tract. Upper GI bleeding from sources like peptic ulcers or esophageal varices may present with vomiting blood or black stools. Lower GI bleeding from conditions like diverticulosis or hemorrhoids usually causes bright red blood in the stool. Management includes resuscitation, endoscopic evaluation, and targeted treatment based on the bleeding source. Malabsorption syndromes. When the body fails to absorb nutrients properly, malabsorption syndromes develop. Common causes include celiac disease, pancreatic insufficiency, and small intestinal bacterial overgrowth. Symptoms include chronic diarrhea, weight loss, and nutrient deficiencies. Diagnosis involves stool fat tests, breath tests, and endoscopy with biopsy. Treatment focuses on addressing the underlying cause and providing nutritional support to gastrointestinal manifestations of systemic diseases. Many systemic diseases have gastrointestinal complications. Diabetes can cause gastroparesis and enteropathy, leading to slow digestion and diarrhea. Scleroderma affects the esophagus and intestines, causing reflux and motility issues. Thyroid disorders can lead to either diarrhea or constipation, depending on whether the thyroid is overactive or underactive. HIV/AIDS increases the risk of opportunistic infections and GI malignancies. Nutrition and gastrointestinal disorders. Nutrition plays a vital role in managing GI diseases. Malnutrition is common in chronic conditions like IBD, celiac disease, and pancreatic disorders. Tailored dietary modifications, such as a low FODMAP diet for IBS or a gluten-free diet for celiac disease, can significantly improve symptoms. In severe cases, enteral tube feeding or parenteral IV nutrition support may be necessary. Probiotics and the gut microbiome. The gut microbiome consists of trillions of microorganisms that influence digestion, immunity, and even mental health. Probiotics, live beneficial bacteria, may help with antibiotic-associated diarrhea, IBS, and IBD. However, the effectiveness of probiotics varies by strain, and research is ongoing to fully understand their role in gut health. A balanced diet rich in fiber supports a healthy microbiome naturally. Which of the following is not a common cause of chronic secretory diarrhea? Answer: celiac disease. Celiac disease typically causes malabsorptive diarrhea, not secretory diarrhea. Secretory diarrhea occurs due to increased fluid secretion in the gut, which persists despite fasting. Which test is most appropriate for initial evaluation of chronic constipation in a 30-year-old woman with no alarm symptoms? Answer: thyroid function tests. In a young patient without red flag symptoms, hypothyroidism should be ruled out first, as it can slow bowel motility and cause constipation. Which of the following is more characteristic of Crohn's disease than ulcerative colitis? Answer: presence of skip lesions. Crohn's disease is characterized by skip lesions, where normal bowel segments alternate with inflamed areas, unlike ulcerative colitis, which has continuous inflammation. Which antibody test is most specific for celiac disease? Answer: anti-endometrial antibodies. Anti-endometrial antibodies have near 100% of specificity for celiac disease, though anti-tissue transglutaminase antibodies or TTG-IgA are more commonly used due to easier testing. Thank you for joining this session on diarrhea and constipation. These common yet significant conditions affect millions worldwide, and understanding their causes, diagnosis, and management is key to improving digestive health. If you have any questions or need further clarification, feel free to reach out. Wishing you good health and wellness.